After 60, these 5 pills increase the risk of heart attack and stroke. A profound and often imperceptible shift occurs within the human body once it crosses the threshold of 60 years. A subtle, quiet metamorphosis that most individuals unfortunately never consciously perceive. Yet it carries significant implications for their long-term health and well-being, particularly concerning the daily medications they may have relied upon for years without incident. The very same pharmaceutical compounds that were once tolerated with effortless grace and consistent efficacy by a younger physiology can, without any alteration in their chemical composition or manufacturing, suddenly begin to manifest their effects in entirely unforeseen and potentially detrimental ways. This critical change is not attributable to the medication itself undergoing transformation, but rather to the inherent, age-related evolution of the body that processes it, and in certain instances, this evolving difference is far from trivial. It can represent the crucial distinction between sustained physiological protection and an escalating risk, between a state of systemic stability and a slow, insidious accumulation of biological stress that subtly but persistently builds toward profoundly serious cardiovascular events, such as the life-altering impact of a heart attack or a debilitating stroke. What renders this silent physiological transition particularly perilous and cunning is the initial absence of any overt warning signs. There are no immediate sensations of discomfort, no acute pains, no clear and unmistakable signals to alert an individual that something fundamental has shifted within their internal landscape. Instead, it is a gradual background alteration, a quiet recalibration of the body's intricate systems. Today, our exploration will delve deeply into 5 distinct categories of medications that, following the age of 60, have been scientifically and clinically linked to a demonstrably increased risk of adverse cardiovascular events, especially when specific underlying health conditions are present, or when these drugs are continued precisely in the same manner and dosage as they were during earlier decades of life, without the crucial reevaluation demanded by an aging physiology. However, and this is the paramount point that truly matters and must be thoroughly internalized, this comprehensive discussion is emphatically not designed to instill fear or anxiety. Its core purpose is to cultivate a profound and practical understanding of the intricate processes actually unfolding within your body as it matures, thereby empowering you with the knowledge necessary to make more informed, proactive, and ultimately far superior health decisions as you navigate the complexities of aging. I am Dr. William, a practicing medical doctor and physician, and through this platform, I am committed to meticulously deconstructing complex and often intimidating health topics into lucid, accessible, and eminently practical explanations, all with the overarching goal of enabling you to better comprehend the subtle and overt changes that may be occurring within your unique biological framework, and more critically, to discern what interventions and choices genuinely contribute to a positive and sustained difference in health outcomes over the passage of time. If you find this caliber of detailed and actionable health information genuinely helpful, I encourage you to consider subscribing to the channel for continued insights. More importantly, however, I urge you to remain with me through the entirety of this discourse, as one of the medications we will meticulously dissect today is an ubiquitous presence, taken daily by millions upon millions of people across the globe. And yet, it is almost never critically questioned or reevaluated, often regarded as an unquestionable pillar of routine health maintenance. To truly grasp the fundamental reasons why these medication-related risks demonstrably escalate after the age of 60, it is imperative to begin with a foundational piece of knowledge that, surprisingly, most individuals are never explicitly informed of. Your body's sophisticated biological machinery does not process medications in the identical manner it once did during its younger, more robust years. This fundamental alteration in pharmacokinetic and pharmacodynamic profiles is precisely where the critical shifts begin to unfold. As we progress through the natural process of aging, several vital physiological systems within the body inevitably begin to operate with diminished efficiency and a slower pace. The liver, a remarkably complex organ principally responsible for the intricate metabolic breakdown and detoxification of a vast array of medications, becomes progressively less efficient in its enzymatic activities. Concurrently, the kidneys, which function as crucial filters for waste products and excess substances circulating within the bloodstream, also experience a gradual but definite decline in their filtering capacity, a phenomenon often referred to as a reduction in glomerular filtration rate. The collective consequence of these age-related declines is that pharmaceutical compounds tend to remain within your systemic circulation for extended durations, sometimes significantly longer than would be predicted based on younger physiological models. When medications linger in the body for prolonged periods, even what was once considered a normal, standard therapeutic dose can, over time, begin to exert effects equivalent to a substantially higher dose, leading to an increased propensity for side effects and toxicity. But this alteration in drug elimination is merely one facet of a multi-layered story. There is also a profound and consequential shift in how your cardiovascular system, specifically your blood vessels, responds to various pharmacological agents and physiological stressors. Your arteries, which are ideally designed to be pliable and elastic, become increasingly stiff and less flexible, a process known as arteriosclerosis. The delicate inner lining of your blood vessels, the endothelium, becomes more sensitive and prone to dysfunction. Furthermore, microcirculatory patterns can undergo subtle but impactful changes, and the intricate, finely tuned balance between the body's natural tendency to clot blood, hemostasis, and its capacity to prevent excessive bleeding, fibrinolysis, becomes considerably more delicate and susceptible to disruption. Consequently, when a medication interacts with any of these evolving systems, its intended or unintended effects can be substantially amplified or altered, often with unexpected results. This is precisely where many individuals and even healthcare providers not attuned to age-related pharmacology can be inadvertently misled. The medication itself is not inherently or necessarily dangerous. Indeed, it may have been an entirely appropriate, even life-saving intervention when it was initially prescribed years or even decades prior. It may even retain some therapeutic utility in the present. However, the fundamental physiological context within which that medication is operating has undeniably changed. Medicine, more than most people fully appreciate, is profoundly contextual. The very same drug, administered in the identical dose, can prove immensely beneficial and protective in one specific clinical scenario, yet become decidedly risky or even harmful in another. A dosage that was perfectly appropriate and well tolerated at 50 years of age might become decidedly excessive and potentially hazardous at 70. Yet, in the realities of day-to-day clinical practice, prescriptions are frequently continued for years on end without the meticulous, detailed reevaluation that an aging body demands. This is not typically due to a lack of care or diligence on the part of medical professionals, but rather because these age-related physiological changes manifest gradually, subtly, and often quietly in the background, making them easy to overlook without a proactive and specific focus. Here is where the gravity of the situation escalates further. After the age of 60, the inherent baseline risk of suffering major cardiovascular events, such as a heart attack or stroke, naturally and incrementally increases simply due to the aging process itself. This is a well-established and universally acknowledged epidemiological fact. However, when certain categories of medications are subsequently layered on top of this already elevated baseline risk, particularly without conscientious adjustment for the aging physiology, they possess the capacity to significantly push that risk even higher. Sometimes this augmentation of risk occurs subtly, almost imperceptibly. At other times, it is remarkably significant, and disturbingly, it often transpires without any clear or obvious symptoms manifesting until a catastrophic event unfortunately occurs. This profound reality underscores why today's topic holds such immense importance. We are not merely discussing abstract pharmacological agents. We are engaging in a crucial dialogue about the dynamic and evolving manner in which your unique body interacts with these medications right now, at your current stage of life, with all its inherent physiological changes. And, perhaps most importantly, we are exploring what concrete, actionable steps you can realistically take to mitigate these emerging risks. Before we delve into the specifics of the first two medications, it is vital to internalize one overriding and critically important idea. Nothing we are about to discuss should be interpreted as a directive or encouragement for you to independently cease taking any prescribed medication on your own initiative. That is unequivocally not the objective here. The overarching goal is the cultivation of heightened awareness. For when you possess a clear and comprehensive understanding of how something functions within your body, you are empowered to formulate more insightful and pertinent questions. You can engage in more informed, collaborative, and productive conversations with your healthcare providers, and crucially, you can avoid remaining on an unthinking autopilot with a medication regimen that may be in urgent need of thoughtful adjustment or reconsideration. This is precisely where the initial layer of enhanced cardiovascular risk begins to emerge, as the first two categories of medications we will scrutinize are among the most ubiquitously utilized, particularly within the demographic age 60 and beyond. They are frequently administered on a daily basis, are broadly considered to be safe and well tolerated by the general public and many clinicians, and yet, under specific physiological conditions inherent to aging, they possess the stealthy capacity to quietly impose additional strain on the delicate musculature of the heart, subtly alter blood pressure dynamics in an unfavorable direction, or adversely affect the smooth and efficient flow of blood through vessels that are already rendered more sensitive and compromised by the aging process. Once you comprehend the intricate mechanisms through which these effects manifest, you will begin to appreciate why this critical discussion transcends the mere properties of the pill itself. It becomes fundamentally about precise timing, appropriate dosage, and the profound, undeniable fact of how your body has progressively changed over the years. And that, unequivocally, is the exact direction our discussion will now take. Let us commence with a medication class that is extraordinarily common, a group of compounds that countless individuals ingest without a second thought, often for protracted periods spanning years, and in many cases, even decades. Yet, once the body reaches the age of 60, these medications often begin to behave in a profoundly different and sometimes problematic manner within the internal physiological milieu. The first such group comprises what are known as non-steroidal anti-inflammatory drugs, or NSAIDs. This extensive class encompasses readily available over-the-counter mainstays such as ibuprofen, for example Advil Motrin, naproxen, for example Aleve, and also includes various prescription-strength anti-inflammatory formulations. Their widespread application spans the relief of joint pain, chronic back discomfort, the management of arthritis symptoms, and the general amelioration of everyday inflammatory processes. For a significant proportion of the population, NSAIDs present themselves as an elegantly simple solution. One takes a pill, the pain sensation mercifully recedes, and the individual can then resume their daily activities with renewed comfort. However, beneath this seemingly straightforward surface, a more complex and potentially perilous cascade of events is simultaneously unfolding within the body. NSAIDs exert their primary therapeutic action by inhibiting the activity of specific enzymes, primarily cyclooxygenase, COX-1 and COX-2, which are intricately involved in the biochemical pathways of inflammation. This inhibition is precisely what accounts for their potent pain-reducing and anti-inflammatory properties. Crucially, however, these very same enzymes also play indispensable roles in maintaining the structural integrity and protective functions of your blood vessels, as well as in regulating the intricate mechanisms that ensure proper and unobstructed blood flow throughout the circulatory system. This dual action is where the core issue for older adults begins to manifest. After the age of 60, as previously discussed, your blood vessels are already characterized by reduced flexibility and elasticity. The delicate inner lining of your arteries, the endothelium, becomes inherently more sensitive to various forms of physiological stress and external interference. When NSAIDs intervene with and disrupt this vital protective system, it can precipitate a subtle yet significant tightening or vasoconstriction of the blood vessels. This gradual narrowing and tightening of the arterial lumen invariably leads to an increase in systemic blood pressure, an elevation that is not always immediately apparent or subjectively noticeable by the individual. It can be a slow, quiet, yet persistently escalating effect that accumulates over time. Concurrently, NSAIDs can also directly impair the kidney's ability to meticulously regulate fluid and electrolyte balance. Specifically, they can induce the body to retain an excess of sodium and water, a phenomenon that significantly augments the total fluid volume circulating within the cardiovascular system. This increased fluid load, in turn, places substantial additional strain on the heart, forcing it to work considerably harder to pump blood through the body. Thus, an aging individual experiences a dual physiological burden, simultaneously elevated blood pressure and an increased circulating fluid volume. For someone whose cardiovascular system is already operating with diminished reserve and increased effort after the age of 60, this perilous combination of effects is profoundly significant and can have serious consequences. Numerous large-scale epidemiological studies and meta-analyses have unequivocally demonstrated a robust association between the long-term or frequent use of NSAIDs and a statistically significant increased risk of experiencing a heart attack or stroke, particularly within older adult populations or those who present with pre-existing cardiovascular risk factors such as hypertension, diabetes, or a history of vascular disease. This is precisely where individuals can be critically misled. The immediate and tangible relief from pain provided by NSAIDs is compelling and often prompts continued use, but the underlying cardiovascular impact builds slowly, insidiously. One does not possess the capacity to subjectively feel their blood pressure gradually rising in real time, nor does one perceive the incremental, day-by-day addition of strain on their arterial walls. Yet over the protracted course of weeks, months, and years, these subtle physiological insults accumulate, quietly eroding cardiovascular resilience. Now, a critical distinction must be made. This elucidation does not imply that NSAIDs are inherently bad or should be universally avoided. Rather, it emphasizes that their judicious and safe use necessitates a heightened level of awareness and careful consideration. Short-term application for acute pain, occasional use for episodic discomfort, or carefully monitored administration under specific medical guidance may still be entirely appropriate and beneficial. However, the routine, daily, and protracted use of NSAIDs without regular and thorough reevaluation in individuals over 60 is where the cardiovascular risk profile undeniably begins to escalate to concerning levels. This brings us seamlessly to the second category of medication, one that is arguably even more subtle in its insidious effects and, consequently, even more consistently underestimated in its potential impact on cardiovascular health. This refers to a class of drugs called proton pump inhibitors, commonly abbreviated as PPIs. This group includes widely recognized medications such as omeprazole, e.g. Prilosec, esomeprazole, e.g. Nexium, lansoprazole, e.g. Prevacid, pantoprazole, e.g. Protonix, and other similar pharmaceutical agents specifically designed to reduce gastric acid secretion. They are extensively prescribed for a panoply of gastrointestinal conditions, including symptomatic acid reflux disease, persistent heartburn, erosive esophagitis, and for the crucial protection of the stomach lining, especially in individuals who are concurrently taking other medications, such as NSAIDs, that are known to be irritating or damaging to the gastric mucosa. On the surface, PPIs appear to be remarkably benign and universally harmless. They effectively diminish stomach acid, provide profound relief from gastrointestinal discomfort, and offer a protective shield to the stomach lining. However, this is precisely where the situation becomes significantly less straightforward and the less obvious long-term ramifications begin to emerge. Stomach acid is not merely a noxious agent responsible for causing discomfort. It plays a vital and indispensable role in a multitude of digestive processes, including the efficient absorption of several key micronutrients from the ingested diet. This is particularly true for essential minerals like magnesium and calcium, as well as for vital vitamins such as vitamin B12. Over time, the chronic, long-term use of PPIs can significantly impair the gastrointestinal absorption of these critical nutrients, leading to insidious deficiencies. While this might not immediately sound directly pertinent to the risk of heart attack or stroke, the connection is, in fact, quite profound and direct. Magnesium, for instance, is an electrolyte that plays an absolutely critical and multifaceted role in maintaining the electrical stability and rhythmic regularity of the heart muscle. Chronically low magnesium levels, hypomagnesemia, can substantially increase the propensity for developing irregular and potentially dangerous heart rhythms, arrhythmias. Similarly, calcium balance is intimately involved in myriad physiological processes, including nerve signal transmission, muscle contraction, including cardiac muscle, and crucially, the overall function and tone of the vascular system. Disruptions in calcium homeostasis can indirectly impact cardiovascular health. Furthermore, vitamin B12 is indispensable for a variety of metabolic functions, including the production of healthy red blood cells, and importantly, in processes that maintain the structural integrity and optimal function of blood vessels and nerve cells. When the delicate balance and optimal levels of these vital micronutrients are chronically disrupted over extended periods due to PPI use, the entire cardiovascular system can become progressively more vulnerable to various insults and dysfunctions. But the complexity deepens with another critical layer of research. A growing body of scientific inquiry has suggested that protracted PPI use may exert a direct adverse effect on the function of the endothelium, the exquisitely thin and vital inner lining of all blood vessels. This endothelial lining is not merely a passive barrier. It is a highly active and dynamic organ in its own right, playing an essential role in regulating blood vessel tone, controlling blood flow dynamics, modulating clotting processes, and facilitating vessel relaxation. When this critical endothelial function is impaired or compromised, the intrinsic risk of experiencing various vascular events, including atherosclerosis progression, thrombosis, and subsequent heart attack or stroke, demonstrably increases. Again, it is imperative to reiterate that these adverse effects do not manifest abruptly or overnight. They are the product of a slow, quiet, and incremental buildup, often progressing entirely without clear or alarming subjective symptoms until a significant event occurs. Herein lies a common misconception and a prevalent error in clinical practice. Many individuals are initially prescribed a PPI for a circumscribed short-term issue, such as an acute episode of acid reflux, stress-induced stomach irritation, or a temporary need for gastric protection. However, due to a lack of explicit reassessment, or simply because the medication feels safe and provides relief, they continue taking it for years, sometimes for a lifetime, without a critical review of its ongoing necessity or appropriateness. Because it was initially prescribed by a doctor, it is often unquestioningly trusted, and since nothing overtly feels wrong, the continuation becomes an unthinking habit. But the longer this unexamined continuation persists, the more the underlying, often subtle, adverse effects begin to accumulate and to matter profoundly. This is precisely where heightened awareness becomes a game changer, fundamentally altering the trajectory of health management. Because sometimes the optimal solution is not the abrupt cessation of the medication altogether, which could, in some cases, lead to rebound hyperacidity or other issues. Instead, it may involve strategically adjusting the duration of therapy, rigorously reassessing the true ongoing need for the medication, exploring the feasibility of a lower effective dose, or proactively investigating alternative therapeutic approaches, including lifestyle modifications or other pharmacological agents with a different risk profile. Crucially, however, such informed and personalized adjustments only come into consideration when the pertinent questions are consciously and deliberately asked, initiating a dialogue between patient and healthcare provider. What we have meticulously covered thus far represents merely the initial layer of understanding. Two extraordinarily common categories of medications, each operating through distinct physiological mechanisms, yet both sharing the capacity to quietly and incrementally augment cardiovascular strain over extended periods. However, the subsequent medications we are about to discuss delve even deeper into the intricate workings of the cardiovascular system. The next two categories do not merely influence blood pressure or micronutrient levels. They interact directly and profoundly with how your heart functions, how your blood circulates throughout your vascular network, and critically, how your entire system responds under various forms of physiological and psychological stress. Once you achieve a comprehensive understanding of these deeper interactions, the overall picture of age-related medication risk becomes dramatically clearer and more coherent. Now, our discussion begins to pivot from the realm of subtle, almost imperceptible shifts to something far more overtly significant in its potential ramifications. This is because the next two categories of medications exert influences that extend well beyond merely affecting blood pressure or modulating nutrient absorption. They engage in direct and impactful interactions with the core operational dynamics of your cardiovascular system, particularly concerning its behavior and resilience when subjected to stress. And in a great many instances, their adverse effects are far from immediate. Instead, they insidiously accumulate over months and oftentimes even years, which is precisely why their critical importance is so frequently overlooked or completely missed in routine clinical assessments. Let us proceed with the third category, a class of medications extensively employed for the management of sleep disturbances, the amelioration of anxiety symptoms, or for achieving a general calming effect on the central nervous system. These powerful pharmacological agents are collectively known as benzodiazepines. Prominent examples within this class include diazepam, for example, Valium, lorazepam, for example, Ativan, alprazolam, for example, Xanax, and other structurally similar compounds. Their efficacy is undeniable. They can rapidly and effectively diminish acute anxiety, provide significant assistance with the initiation and maintenance of sleep, and offer symptomatic relief for states of heightened nervous system arousal. For a substantial number of individuals, particularly as they progress into later life, these medications can feel like an indispensable and necessary support system, providing a much-needed sense of tranquility and respite. However, it is vital to understand the profound cascade of events that unfolds beneath this surface-level therapeutic effect. Benzodiazepines exert their primary action by enhancing the effect of the neurotransmitter gamma-aminobutyric acid, or GABA, in the brain, thereby slowing down central nervous system activity, which is precisely what generates their characteristic calming, anxiolytic, and hypnotic effects. Crucially, however, this generalized slowing effect is not exclusively confined to the brain. It extends to other vital physiological systems throughout the body, including the delicate control of respiratory function, leading to slowed or shallow breathing, the speed of reaction time, and the precision of physical coordination. One might logically ponder, how does this physiological deceleration directly connect to an elevated risk of heart attack or stroke? This is where understanding the specific mechanism and age-related physiological changes becomes critically important. As the body ages, its sensitivity to these particular medications markedly increases. Benzodiazepines tend to remain in the systemic circulation for more prolonged periods in older adults. They accumulate more readily in the body's tissues, and their pronounced sedative effects become significantly more potent, even when the dosage remains identical to what was prescribed years earlier. Over an extended period, the cumulative effect of this enhanced sedation can lead to a demonstrable reduction in overall physical activity, a diminished inclination for movement, and consequently, more prolonged periods spent in sedentary postures, such as sitting or lying down. This seemingly innocuous reduction in activity holds far greater significance than most people fully grasp. Because efficient blood circulation, the lifeblood of tissue oxygenation and waste removal, is fundamentally dependent upon regular physical movement. When an individual's movement patterns decrease, the efficiency of blood flow throughout the body concomitantly declines. This less efficient circulation, in turn, elevates the inherent risk of dangerous blood clot formation, thrombosis, and the delivery of vital oxygen to all bodily tissues becomes less than optimal, stressing cellular metabolism. But there is yet another critical layer to consider. Benzodiazepines can also adversely affect breathing patterns during sleep. They possess the capacity to induce or exacerbate shallow breathing, hypoventilation, or to worsen pre-existing sleep-related breathing disorders, most notably obstructive sleep apnea. When the body's oxygen saturation levels repeatedly and significantly drop during the nocturnal hours, even if these drops are relatively subtle individually, the cumulative effect imposes substantial additional strain on the already aging and potentially compromised heart muscle. Therefore, in older adults using